supply are stem cells, platelet-rich plasma, hyaluronic acid, or viscous supplementation products, things of that nature. Raise a hand. Is this something altogether new to many of you, or are you somewhat familiar with it? Well, I've been having a lot of patients walk in and asking me about, these things that are being done, and not only in our community, but around the country and around the world. And I thought, well, about time I had a little better answer for people when they ask me the question, what about it? Does it work? Is it worth the money? Is it a viable idea? Does it make a difference? I think it's important to recognize that this is not mainstream rheumatology. We do viscous supplementation with hyaluronic acid, but we don't do stem cells and platelet-rich plasma. Most of this work comes out of sports medicine, and a lot of it's actually been done in Europe over the years. The sports institutes in Europe are well funded. These countries over there put a lot of money into their sports and their athletes in terms of the sports medicine program. So many of them are done there. They're very well done trials, but there's a lot of limitations. So we'll talk about that a little bit. So I thought I would just see if I can make this work. Okay, do I have to aim it over there? What am I doing wrong? I'm pushing the wrong button. Oh, there we go. I need to stand back there. Might actually be easier for me to see my slides. Okay. Hello. Wow, there's a couple seats up here. Yeah, it's a little close up there. It's like being in the front row of the cinema, isn't it? Well, anyway. So the reason I decided to do this little talk is to find out enough information so I can answer patients' questions and stuff effectively and with some reasonable certainty that I know something about it. Okay. Well, just a little preface. Osteoarthritis is a word many of you probably have heard many times. It's also known as degenerative arthritis, and it's common. It's the most common form of arthritis we suffer as Americans. 1 out of 7 Americans has significant clinically disabling arthritis related to osteoarthritis of the knee. It's very common. The risk rises with age. The symptoms and signs are typically pain with use. When you move it hurts. If you put weight on it hurts. It's usually more painful after you overuse it or after a period of inactivity and you start to move once again. The bones tend to enlarge with this disease. It's not associated with inflammatory synovitis to the degree that we see in autoimmune forms of arthritis, such as rheumatoid arthritis. The joints tend to make noise, up and down steps and getting out of chairs, they pop and grind and say, oh my gosh, what's happening? They tend to swell at times, some don't, some do. We call those joint effusions. And we often aspirate the fluid, find out what's really going on. It's a nice, very good diagnostic tool. And you may see deformities. You may see knees that are bow-legged or knock-kneed. hence the term varus valgus. So what causes it? Well, in large part, many forms of it, particularly that seen in hands, are ladies who are menopausal, who have what I call the knobby knuckle syndrome, have a hypertrophic osteoarthritis of the hands. It's autosomal dominant, and we won't talk about that tonight. You can see seen in men just as well. Again, it's genetic in men as frequently. Being overweight doesn't help weight-bearing joints very much, and if they happen to be prone to osteoarthritis, obesity doesn't help. Injury, of course, all our football players who've had their meniscus removed, you can count on 80% of them have osteoarthritis by the time they're 45. And again, overuse. If you beat a joint to death, it won't last forever. So you have to be aware of overuse syndrome too. So your knee hurts. So you get up in the morning and it's a little swollen. You can see the other knee looks a little bit swollen as well. Okay. Making the wrong moves here, sorry guys. It's a little bit swollen and it has inflammation in it that's not autoimmune in nature, but it's definitely inflamed. It'll be warm. You can feel the swelling. And the bones tend to enlarge and get big around the edges. The radiographs go from normal to abnormal. You can see the medial compartment of this knee is starting to thin down. There's a small spur on the edge of that bone, known as an osteophyte. That's definite osteoarthritis. It's not end stage, but it's clear-cut, asymmetrical narrowing with osteophyte formation. That's the definition of osteoarthritis of the knee. This is more advanced. You see the lateral compartment is very narrow, hardly any cartilage left. And there's spurs on the edge of the patella, on the edge of the femoral condyle, and on the edge of this tibial plateau. Arthroscopically, we see changes in this lovely white, glistening hyaline cartilage that you see there's a defect in that cartilage. That's what osteoarthritis looks like. Microscopically, when it's very early, it starts to become sort of granular and has small cracks in it, like the dry river creek bed. And little by little, it flakes away and it's mechanically worn. Unfortunately, over time, our cartilage changes chemically. A lot of the collagen has sulfide bonds in it, and those sulfide bonds break down over time and result in cartilage which is not as well hydrated. The chondrocytes don't live in that cartilage as well, and they move away and disappear. And without normal cartilage, you don't have the stimulation within the knee joint to stimulate the fibroblasts, which are the cells that make hyaluronic acid. Hyaluronic acid is the lubricant of your knee. And so as your knee degrades, a lot of things interact with each other and lead to more advanced changes. And little by little, it gets worse. So the treatments, now this is basically a slide that I made some years ago, and I just thought I would show you this. This hasn't changed a whole lot over the years. We see that we have medications. American College of Rheumatology guidelines emphasize acetaminophen as a first-line treatment. Non-steroidal anti-inflammatory drugs are aspirin substitutes that were designed originally to provide anti-inflammatory effects and analgesic effects in people who couldn't tolerate aspirin. And some of them certainly are more easily tolerated than aspirin. Particularly if you're over 40, aspirin tends to make your ears ring and turn deaf quickly if your salicilated levels become therapeutic. That is aspirin levels in your blood. They're very useful, but they're by no means curative. Corticosteroids have been around for a long time, originally developed for treatment of rheumatoid arthritis. We use them within joints. We inject them into the joint to reduce symptoms and temporary reduction in the inflammatory response. Again, not an autoimmune response necessarily, but definitely there's a degree of inflammation. I see this readily when I look at on my ultrasound at knees, these fronds of villous fronds of synovitis show up. The glucosamine chondroitin sulfate story has been around forever. There was an NIH study that we participated in a number of years, one of the research center sites, and that was published later and was found to be marginally effective in some patients some of the time. It certainly was not a panacea. An interesting thing I've discovered recently, if you look at the American College of Rheumatology guidelines for osteoarthritis and all the various things we do, this concept of using Tai Chi exercise to improve your flexibility, your tone, and your strength, as it produces a 36 to 40% improvement in symptoms of pain and functionality. Frankly, that beats all the medications we use, hands down. It's not difficult to do, but one has to be motivated, but it makes a huge difference. And there's clinical trials that actually show that. Weight management is key. As I always tell people, our bodies are like funnels. Everything at the bottom is very concentrated. And at the ankle, it's 4 times your body weight, pounds per square inch. At the knee, 3 times your body weight, etc. So it behooves us to manage our weight properly, no matter what kind of arthritis we have. And finally, since the late 60s, when the first total hip was done in Britain by a fellow by the name of Dr. Charnley, many our joints can be replaced at this point in time. This basically is medical failure management. We've failed medically to stop the progression of this disease, and that's the sad story, unfortunately, that we are faced with this diagnosis of osteoarthritis. So just to summarize a little bit, we'll talk a little bit about these different items and talk about their effectiveness and their use. First of all, corticosteroids. This is adrenal corticosteroid-driven drug. It's discovered by some rheumatology a rheumatologist by Dr. Hensch and a biochemist by the name of Dr. Kendall at the Mayo Clinic in the 1940s. And it was first used in rheumatoid arthritis in those late 40s and was provided the Mayo Clinic, placed on the map when a Nobel Prize for this particular product in the field of medicine was given to Dr. Hensch and Dr. Kendall. We basically inject it in the joint. You can do it in a sitting position or lying down, depending on. You basically have to thread it between the bones and put it in the space. And it's not terribly difficult to do once you learn the landmarks and have it practiced a few times. The main element is good body positioning and good mechanics when you do it. The question is, does it work? Well, everyone agrees that it reduces symptoms, but it has limited lifetime expectancy. If you do it repetitively, it diminishes in effectiveness over time. If it lasts 3 months, that's a pretty reasonably good response. If it lasts longer, that's a bonus. But it does not reverse the changes of osteoarthritis. In fact, some authorities feel that it actually may cause progression of osteoarthritis and loss of cartilage prematurely. It's always important to take the fluid out. Just an ultrasound guided aspiration. Put the needle in there. Using the ultrasound, you can see where the fluid is. This dark area is the water in your knee. This is the synovial tissue down here. That's the bone. So we pull out that fluid and then inject your corticosteroid product or whatever else you might be injected. It's better to have the fluid out there. All the clinical trials tell us that having the knee empty of fluid improves the benefit of the product you're putting into the knee. So viscous supplementation. Basically, there's a large number of hyaluronic acid products, period. Okay, I'm going to dictate tonight. Been doing it all day, I can't stop now. At any rate, it's the same thing they put in cosmetics. You go to the Estee Lauder counter and in the products they sell, all the anestheticians put it on your skin and it makes it feel smooth and sort of fills in the cracks. It really is a very nice lubricant. It's really not, you say, well, why is it an acid? Well, it's just the name of it. It's Hyalan, 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 in many papers. There are a number of products. The first one that came on the market was Synvis, and that's the one we still use in our office. It's actually rooster comb equivalent protein. take a rooster comb and break it down. This very thin protein is in a rooster comb. And so when people come in, I want some of your rooster juice, and that's why they use the term rooster juice, because it actually is derived from the honeycomb of chickens. So it provides a lubrication, but it does a number of other things. It actually tends to improve the elasticity and the viscosity of the fluid within your knee. It regenerates and helps hydrate the cartilages in your knee. It does a nice job of doing that, and actually produces some very positive results for some folks. I just wanted to let you know that in the medical literature, and I'm reviewing this topic, there were 15 really good analyses of multiple trials that have been in the medical literature. And there were 15 trials that were worth looking at that had sufficient data and sufficient quality to be reviewed by experts in the world from all over the country, many countries. Many physicians who are experts in this field looked it all over and felt there were 6 trials that actually showed a positive result. There were 4 that were so-so and seemed to be okay, but there was a definite improvement. And there were 2 that were felt not to be any better than placebo. And it basically compensates for the reduction in the hyaluronic acid that's in the knee joint, and it decreases since the protein in osteoarthritic knees is not the quality that it was. It becomes a shorter protein and it's less able to lubricate the joint. So you're refurbishing those qualities of the hyaluronic acid within the knee joint and compensating for those changes. It's interesting, though, that the product actually does some things to some of the immune products that are inside the knee. So there seems to be some interaction with the immune system locally within the knee joint that helps protect the cartilage and improves the collagen synthesis within the joint. That appears to be anti-inflammatory. And it also has been shown that repetitive sequential injections over time seem to sustain their benefit, and it's worthwhile doing. No one product is definitely better than the other. There are very few head-to-head trials. In fact, there's only one that I could find, and they basically said they were fairly equivalent products. So it has some value, and it's worth doing. American College of Orthopedic Surgeons actually has a statement on the web that says they don't recommend it. But I can tell you there's an awful lot of orthopedic surgeons out there that inject it for people as an option prior to any operative procedures. American College of Rheumatology feels it's an appropriate use to be used in people that are non-steroidal anti-inflammatory drug failures and failed all other conservative measures, or people that simply can't take non-steroidals at all because of their medical health. And it's basically a substitute for non-steroidal anti-inflammatory drugs in that group of individuals. So the injection goes in, and this diagram shows that there's a reduction in inflammation. It's no longer red, it's turned a little blue. So that's a cooled off joint, fortunately. So what about platelet-rich plasma? It's a pretty hot topic. It's been around for a while. The wound centers, for example, use platelet growth factor. Platelets produce a lot of products that stimulate healing in not only the skin, but tendons and ligaments and whatnot. So it's part of the sports medicine as well as the wound healing process to have platelet growth factor that stimulates improvement in blood vessels in the region as well as the tissue growth. And so there's some real value in it in terms of wound healing. In the terms of what's being done in joints, basically take some blood and you spin it down several times until you get a platelet concentrate. You take this plasma and then you put it into this processor that photo activates the PRP, and then you inject it in the joint. This is widely done around the world and is unfortunately seems to be reasonably safe, doesn't seem to have a lot of side effects, people tolerate it well, and some people swear by it. But unfortunately, the clinical trials, once again, are not consistently supportive. That's the thing that's kind of frustrating about it, and that's probably why Medicare and insurance companies aren't going to pay for it, because there's not enough clinical data to support its use in this diagnosis. So if you go to one of these places like Regenerex, if you go online and read about this, they do this. There's centers around the country, and it's cash on the barrel, so you're not going to find your insurance companies involved in this process. This is a kind of an interesting slide that I found from one of the review articles that summarize the results, and I think it's important to notice some of the things that are interesting about this is that all over here it talks about blocking various immune products, IL-1, TNF-alpha, and blocking the production of metalloproteinases. So there's some immune effects locally within the tissue of the joint and the cartilage, and the presumption is this improves the health of your the cells in the cartilage of your joint and reduces inflammation by interacting with some of these factors. This has all been done in vitro in a lab where they take a piece of cartilage, living cartilage, and then subject it to this process and measure various products within it using flow cytometry techniques to find out exactly what happens when the platelets concentrate is put into a cartilage, a piece of cartilage. So what about stem cell therapy? Well, stem cells is a very popular topic. The umbilical cord stem cells, and the issue of aborted fetuses and their stem cells. Has been on the news for years and years. So we've heard this term. The question is, what exactly is a stem cell? That's the first question. Well, it's a cell that has the potential to do a lot of different things. It reduces inflammation, potentially. It self-replicates readily, kind of has its own little motor. It can differentiate into other tissues, including potentially cartilage, bone, muscle, fat, and it also has a lot to do with fighting apoptosis. Apoptosis is premature cell death. So that's one of the key things when it comes to cartilage preservation inside the knee. Again, you can extract flat cells from the abdominal wall. You can use bone marrow sources. Peripheral blood can be done, but it's hard to get enough blood to get enough stem cells to do that much. So bottom line is you basically find some mesenchymal stem cells in whatever source. It's it's separated from the other tissue around it. It's put into a activating gadget, and finally it's injected into whatever joint you feel is appropriate. It's interesting, I had a chance to talk with Dr. Molka with Nebraska Orthopedic Sports Medicine. They've done 10 of these in people with premature hip disease, and it's quite a process. You have to extract the bone marrow. You have to have a trained perfusion expert come and do this process for you. Just anybody off the street knows how to do that. The one that's in this area goes from hospital to hospital, and clinic to clinic, doing it for many, many people. And you have to have the kit to do this. It's the expensive part, plus the manpower and the time. I can see why logistically it's going to cost some real dollars, because there's a lot of manpower and physical time as well as expertise involved, not to mention the materials that are required to do this whole process. But the bottom line is, once again, just exactly what are the results. There was a really nice study that came from the Netherlands and was sponsored by the Olympic Committee and many other centers in the Netherlands. It's a hotbed for sports rehab medicine in this world. They do it probably better than anybody. And what the bottom results were, there were 5 randomized trials that they looked at that were controlled, actually were blinded to some extent, so that the person doing the procedure and the person observing the results were independent and blinded to each other. They would know what the person was given or whether they were, so they try to take the observational bias out of it. But there's a way to do that, and there's a better way to do that, and that's been graded by a system of that researchers use to grade clinical trials. And these trials, in large part, fail to meet the criteria to provide enough quality information to say, yes, we can recommend this as a treatment therapeutic option for the treatment of osteoarthritis of the knee. And again, the people involved were experts in their field, and they had plenty of funding to do it right. So they put a lot of time and effort into reviewing all the subjects. In large part, the studies were small numbers. They were done in different ways. The material utilized was extracted in different ways and processed in different ways. So there was no uniform product. There wasn't any uniform blinding. There were MRI scans done on many of them. There were arthroscopic procedures done on many of them before and after. And again, there was a lot of observational bias built in the way the studies were done. So bottom line is, it's going to take a multi-center, well-designed study with uniform products and uniform blinding to really produce a scientific method before we can actually say, without any doubt, this is an advisable thing to do. So it's kind of frustrating, but that's not terribly unusual in medicine. Many times in medicine, it takes a lot of observational trials before someone has enough gumption and money to afford doing a clinical trial like that. It would be very, very expensive to do. And the end result is, it's not funded well by any one person. So if there's some way we could get enough funding through a government grant or whatever it might take, some individual who has, we should talk to Warren, maybe he would help us out. But we don't have enough quality information to say, yes, this is a great idea. And as long as the data is not there, it's not going to be funded by Medicare or the insurance industry. So right now it's out of pocket. I am quite surprised the number of patients I've had walk into my office who've done this. Most of them have gone to Denver, where there's one of those Regenerex facilities. So I think it's fascinating. I mean, the potential for some results based on what we do know about the science of what these cells do and don't do when they are activated by chondrocytes or cartilage cells, as they're called. That's the name of the cells in the cartilage. The chondrocytes and the collagen in the joint do stimulate these cells to release products which potentially can heal and grow and regenerate tissue. But we haven't enough data to say without, some reckoning that we might be wrong. So I will stop there to let you know. I'm sure everybody wanted to come and hear that, how great this stuff was. I think it's fascinating information. There's a lot of things are known about this approach, but the data to support its use is lacking for the most part. So most of it's very anecdotal, and it's very interesting how much the placebo effect can happen. I thought I mentioned with corticosteroids, in fact, this very month in the Journal of the American Medical Association, there was an article published from Tufts University in Boston, and about 70-some patients per group receive either cortisone in the knee joint or saline, or salt water. And they followed these patients for a number of months. And the bottom line was, it didn't seem to matter what we put in the knee joint. They all felt better for a while. So that was kind of disheartening when you hear that. But but they also pointed out, and the editorial also pointed out, there were a lot of flaws in that study as well. There wasn't a uniform group of patients. There wasn't a uniform set of criteria for entry. They took people randomly, and it wasn't a terribly well designed study. But I noticed ABC News picked up on it right away. So there you have it. I will be happy to answer any questions. Well, that's the wish. At the very least, they hope that it would stall the progression of the destruction of the cartilage. And there is some evidence that using MRI evidence, the cartilage degradation is delayed slightly. But that's not been uniformly studied in all these trials. So again, it's kind of hit and miss on which trials do what. But there's some suggestion that it may do that. But it's not consistently proven once again. So yeah, the idea is, it'd be lovely if you could put something there and make the cartilage all grow back. But that's not obviously been happening. What they do show is that many of these trials were done, and they used not placebo, but they used hyaluronic acid as their control group. So they're comparing hyaluronic acid to stem cells, hyaluronic acid to platelets, platelet-rich plasma. And so there weren't very many studies that actually had a placebo group. It's hard to talk a patient into a placebo trial, believe me. I've been doing that for years. And it can't be for very long, or you lose your patient. That's what makes it hard. But that's the idea. Is the cells, either the platelet-rich plasma or the growth factors and all the things they secrete, help the cartilage do better and survive, or the stem cell in the way it is activated by collagen and the lining of the joint and the chondrocytes. Hopefully will stimulate an environment where cartilage can be healthier and survive longer. Well, ranges from $3,000 to $5,000 per joint. That's one. Yeah, that's what I've heard. Just one injection. This is basically anecdotal, because this is information I've derived from my patients. You can go online and look at the Regenetics website and ask what they might tell you what it costs. I didn't go that far. I didn't want to know. But it's not inexpensive. There's a lot of time and labor involved and expertise in doing it properly, so you don't, infect people with germs and so it's not exactly without some risk. But the interesting thing is the risks seem really low. The complications from injecting corticosteroids, platelets, stem cells, whatever, is very, very low and no greater than placebo. So it's being done technically well, but the question is, what are the results? I hope in another 2 or 3 years down the road we'll see a study that actually says, wow, this is good stuff. We should be giving it to everybody, but we're not there yet. I mean, it sounds great, and it's you think, wow, I'm using my own body's tissues to heal my own tissues. It makes sense in a lot of ways. It doesn't take a lot of scientific knowledge to think, well, that's probably a good idea. My body's a pretty amazing tool. It's a God-given gift, obviously, and it's an incredible machine. And some things heal themselves better than others in our body. I mean, we do well with skin. We do pretty well with muscles and a lot of other tissues. There's some parts of our body that never regenerate, like the lens in our eye, the enamel in our teeth, and unfortunately our cartilage. It's the third one that doesn't do too well in terms of regenerating itself. So it would be lovely if we could do something to make that happen. I don't know anything about that. To be honest with you, I haven't investigated the legality of it. I guess it's not illegal. You go in on your own recognizance and at your own risk and at your own expense, basically. I haven't looked into the credentialing one needs to have to do this. It's done by any number of physicians, ranging from primary care physicians to orthopedic surgeons to physical medicine doctors. The vast majority of these clinical trials are done by physical medicine physicians. Those are MDs that are trained as physical medicine doctors. And they frequently run places like Madonna, for example. They have physical medicine doctors on staff there who are trained to help people with injuries. Hey, how are you? I'm good.